Thank you, Ricardo. Indeed, it is a great honor, and even to be here with some of my heroes, Ivo Jonica, obviously, and Al Roden was the president just before me, so I got to know him very well during that time in the North American Skull Base Society. So what I'm going to talk to, I wasn't really sure, so when Ricardo asked me to speak, I said, well, what should I talk about? He said, well, Ivo will handle the heavy stuff. You just show a few pretty pictures and we'll go from there. And so that's what I'm going to try to do. So I have nothing to disclose. And this is indeed, I'm going to be talking about modern imaging in the development of skull-base surgery in the 70s and 80s. Because there was an amazing transformation that happened in imaging. And I think it did, and I think a lot of people would agree it had an amazing effect on the ability to do the work that you guys do every day in skull-base surgery. It's really, a surgeon once told me, and I'm not sure which one, that imaging changed what they do from exploratory surgery to precision planning. And indeed, high-resolution imaging was really just a major part of, I think, that evolution. So the rapid evolution in the healthcare environment, not so much currently, but I'll be talking about my first transition and back in the 70s and 80s. Now I have all of the 4 logos of the institutions that I'm associated with, and I have to add Pitt because that's obviously where I got my start, got involved with the head and neck imaging and also skull base. So this, I think, puts it in a nutshell. This is exactly where we made the big change. And where is it? Well, this on the side to your left is a tomogram. You would spin the tube one way, the film the other, and everything would blur up a single little section. And indeed, this is the highest resolution image that I've ever dealt with. A chest x-ray, these tomograms have higher resolution than any MR that's been put together, any CT. So what's the difference? What was the major difference in what we see? Well, that was the soft tissues. Being able to see some of the soft tissues as well as just the bone made an incredible difference, and I'll show you some of this. If you see the foramen rotundum, I think I'm showing it about there, and here on MR you can actually see the nerve within on the normal side, and you can also see what we were talking about with Ricardo, the evil gray, making its way along the trigeminal nerve V2 on this side. Well, how did we get there? I'm going to show you some of the images in that evolution. Well, this is how I began. I'm not sure who that young radiologist is, but this is what I learned. First, my training was in angiography and then tomography. But as you can already see, once we got going, these were indeed films that we would hang up on a multi-viewer and look at them like so. But this really was how we started with the highest resolution. And then imaging went through this incredible transformation. And you can already see on the view box, you can already see that these are the CTs. So this was just a couple years into it. But it was an amazing transformation, and just going through it was really daunting, but it was also an incredible experience. So this is where we tend to talk about, or at least give credit to our teachers, and this is where I began. I was sent over to study with Jacqueline Vigneault, who was sort of the queen of tomography and temporal bone, and this is her book, and these were the tomograms. But as we went through the evolution, how did I learn some of this head and neck imaging, the skull base imaging? Well, as we've already had allusion to, I learned it from the surgeons, because the surgeons knew the anatomy. We would figure out something. I would go to the OR, and Gene Myers, Jonas Johnson, Jack Kennerdale were really my original mentors in cross-sectional imaging. In fact, the first cutaneous biopsy I did was with Jack Kennerdale of the Orbit. And then along came this guy with a little bow tie, Ivo Jonica, and along with Shaker, and they just kept getting deeper and deeper into the skull base. Well, I did learn a huge amount from these people, I also learned from the people they were training, because after a few short weeks, they would come down and we would talk about the anatomy, and I would learn. They say, well, I have to see this. And so we would figure out a way. So I wrote them down just so I wouldn't miss the people that are most active in the skull base, but I'm sure I'm leaving out a few. But Dan Nuss, Moy Arriaga, Ricardo, in the flesh right here. But Carl Snyderman, Leonetti, Ehab Hanna, Howard Krause, Chandra Sen. These were all people that really taught me all of this anatomy, and it was an incredible thing. You could go to the OR, they'd help you with dissections, and that's how I figured out some of the anatomy from my perspective. That continues on. You know, and we treasure every time Derek Lynn or Stacy Gray, Ben Blyer come down and we learn a little bit more. And so that really is, and I think any of the radiologists in the audience, number one, go to your clinicians, get their information. Those of you that are the surgeons, help your radiologists, because we all benefit as we do that. So where were we? Well, my training was in angiography, and it's amazing how people would actually plan skull-base surgery from that. Here you've got a CT scan with a meningioma. Well, here is what it looked like on the angiogram. And what we had to rely on would be, you know, the blush, if you will, of the lesion, what the vessels were that were going to it. And some of the neuroradiologists that I learned with, Ralph Hines and some of those people, could just make an incredible diagnosis just by a little bit of displacement of some of the vessels. Here, for instance, this was a subfrontal meningioma, and you can see you're elevating the anterior cerebral, at least I think that's what that is, but you don't get the blood supply. It was a meningioma from the external carotid, but just subtle displacements were able to make a diagnosis of a tumor, and people would actually operate on that information. But what modern imaging was about to show us was the other side. Where are the relationships of some of those lesions? Well, this here is an ICA that's displaced up here by an acoustic neuroma. Here, the petrosal vein, subtle displacement of some of these vessels they could make a diagnosis of, and they were able to go on and do the surgery to help these patients. Here, this is one of the heinous procedures that I learned, was an orbital venogram. We saw some beautiful work on the anatomy of the orbit this morning, and here we used to inject it, put a tourniquet around the forehead, inject, and here you can see for instance, you can see the cavernous sinus with a carotid going through it. I understand there's a little displacement of some of these veins in an orbital tumor. This really was a heinous type of procedure. This is a pneumoencephalogram. And here you can see this was actually done for an acoustic neuroma as well. So some of the early work, this was really, the patient did not enjoy it, neither did the radiologist. And so where could we go from there? Well, here is a tomography, and we saw some things. I think it was Dan Nuss was showing the slides from eras gone past. Whenever we had to publish a tomogram, very high resolution, but we had to make a contact print by ourselves in the darkroom to get it to come. You couldn't just take it with a camera because it wouldn't give you the right resolution. Here, you would always publish it with a tracing of what you were trying to show. Here is a patient with recurrent meningitis, and from this, you could see that you had dye or contrast that's actually in the labyrinth. And this patient had a very significant anomaly with CSF passing into the vestibule. Well, we tried some other things. This was with Pantopaque, and actually we're filling the internal auditory canal. Here, when you look at it right side up with the orbit, here you can see a little bit going into the canal. But this was Pantopaque. Once you injected it, it was going to be there for forever and ever. So we wanted to go on and do some with water-soluble contrast, and for that we had to put together this table, which looks much more dangerous than it is. But we did inject the patient, and then we would have we have a crane right here because the publishers for our manuscript said OSHA wouldn't let us do this. But actually, my chief tech and myself would just stand and push up this table to get the contrast to go where it is. One of the most important parts of some of these procedures is at the final moment, just before you were taking the picture, you would bang the head a few times to set the contrast. Now, you probably don't believe me. Just do a web search on Google, and you can see something from the House Institute showing you exactly how to bang the head. Well, with nitrizamide, with the water-soluble contrast, you didn't have to do that, but you did have to do a C1-2 puncture. I'm sorry there's a light shining on this, but you can see the sort of anatomy that we were looking for. Here you can see, or there you could see, here you can see the seventh nerve going up. You can see the cochlear nerve aperture. Here, if you look along the pons, you can see the trigeminal nerve. And here, this is what an acoustic neuroma looks like, bulging in, keeping the contrast from going into the internal auditory canal. So this is the way, and this lasted for about a year that we did these. But you actually had to do the C1-2 puncture in one projection and leave the needle in, roll the patient up. It's probably not allowed, actually. I know we didn't have any FDA approval, but this is what we did. Now, eventually, very quickly, we started to inject air. And here you can see the little acoustic. Here you can see air. Now, this was not a pneumoencephalogram. This was just a couple of little bubbles. And you would put it up and in there. So it wasn't as nasty to the patient. But again, you did a lumbar puncture, that sort of thing. But you were starting to see even more of the soft tissue in this area. But here was the CT, and actually here is the acoustic. But we would actually, if we didn't see an acoustic and the surgeon thought there was one, that's when we would go to the air, because we didn't have the resolution and we really didn't have the ability to look inside the canal. This was with CT, but we finally got to look inside the canal when you had MRI. And here indeed, as we walk up through this, here is with contrast, and with our first MRIs, we weren't allowed to use gadolinium. That was about 5 years later. But here you can see obviously now the nice acoustic showing up, vestibular schwannoma at the porus. With this resolution, and this resolution was available in the late 80s, here you would actually see the nerves within the canal. You could follow the facial nerve up to the upper anterior edge of the tumor to sort of make you think at least it isn't likely to be a facial schwannoma. But again, the resolution was astounding, but it was the resolution of the soft tissues. To this day, plain film still have a higher resolution, but the ability to see the soft tissue discriminations in these subtle densities or signals are indeed what makes this particular study so useful. Now, go through this. Now, this is really the transition slide, if you will. What I've been showing you up to now is just how we would look at the canal, the internal auditory canal. And all of the question was yes or no. Was there a tumor that was in that area? And indeed, we would go from the different strategies that we had, that was the only question, and the surgery went from there. We had some idea how big it was, but that was about it. But along with MR, now when I'm showing you this glomus tumor, you can see where the real advantage of MRI came to the fore. It's looking at the other side of the tumor, looking at the other side of the lesion, the ones you won't first approach, but what's it doing on the deeper side? And here you can see this glomus tumor, where it is relative to the sigmoid sinus, the skull base. Now we really were indeed into precision imaging. If I could just show a couple pictures of the central skull base and the anterior as well. I know most of what we've been just saying is really the posterior skull base, but if we go on from that, Here, in the skull base, we went from this with angiography and tomography. Here, this is from Chip Youngrice, one of the people that we've worked with, as many of you had. This was not actually done for diagnosis, but we started out with a plain film. You could see the vessels, you could get a lot of information, but here, this one was done really to do an embolization on a juvenile angiofibroma. But if we go to the next image, this is what we can see on MR. This is a different case. This is a carcinoma, but look at some of the anatomy that we can see. We can actually see inside foramen ovale, spinosum, Vidian's canal. We can see the evil gray winding its way through the skull base. Here, an obstructed air cell. Here, tumor of the trigeminal. If we look here, and again, I apologize, some of these are a little dark, but here you've got tumor going up into the cavernous sinus. This is not perineural spread, but it's perineural tumor. The V3 just got in the way as this tumor came through. But again, we can show now very easily all the different cranial nerves in the cavernous sinus. And again, it's soft tissue discrimination that we're really emphasizing on so many of these. Here is a patient with perineural spread. You can follow the tumor going through the pterygopalatine fossa all the way to the cavernous sinus. Here you can see the infraorbital canal, and if you look closely, as we go back a few images, you can actually see the anatomy within the infraorbital canal on the other side. So precision imaging, we can follow this all the way back through into the pterygopalatine fossa, and then further through rotundum and back to the region, not of the cavernous sinus, we actually can follow it back to the region of the Gasserian ganglion and really show precision in the imaging that we're trying to illustrate. Here, we were talking, and Ivo was talking about perineural spread. Here, you can see a little bit of, well, is it really abnormal? Well, the lateral pterygoid is a little bit atrophic, but as we go up, you can see the normal anatomy with fat, lateral pterygoid, maybe even the tensor veli palatini, but on this side, you can see the evil gray, which is right along V3. And we can see this very precisely and follow it up all the way into the region of the cavernous sinus. And here you can see it in the coronal plane as well. So precision, being able to show each and every nerve and see the other edge, we've become very accurate, and I think that has had a profound effect on skull-based surgery. Here you can see a patient with both CT and MRI. Here you have tumor around the optic canal, carotid impression, but here you can see with the CT gives you a little bit better bone anatomy. So working with the different tools, we can really decide where things are. Now, Ivo showed one of the very early CTs with transparency. Here is one of the very early fusion of MRI and CT data, just to show you a very quick view of the anterior skull base. Now, again, we used to be able to say that there was a mass, but now we can say it's going into the orbit, it's going intracranially, and here you can actually see, for instance, the olfactory bulbs just above the cribriform plate. So really precision imaging is what it's all about, and I think that's the big contribution that imaging has done. So we also, on MR, you can actually see with the various protein analyses where exactly the edge of the tumor is and what's just an obstructed sinus. So, where are we going from here? And where did we go? And the most recent big advances, I think, are really in resolution and speed. So here we can see smaller and smaller objects. We hear a dehiscence of the superior canal, but we can get these images with modern MR scanners. Instead of 10 minutes, you can get it in 3 minutes. And that just goes faster and faster. Going forward, we have to talk about functional imaging. We always have to now talk about artificial intelligence. Remember that each of these is just a set of pixels, and the human eye can pick out some relationships. You're actually taking away information to show you these images. But artificial intelligence can actually see the relationship of the pixels, and we're beginning to use it to see how well a patient's doing, as well as how far exactly the tumor has gone. So a lot of things are going to be coming in the near, not too distant future. So again, I want to thank Ricardo for this very kind invitation. It's an honor and a privilege, and to be even on the stage with Ivo and with pictures of Al Roden, I think is really one of the highlights of my career. So thank you very kindly for listening, and I'll turn it back to Ricardo.